a hearty welcome to the residents from Ethiopia, Ghana, Nepal. We have such an exciting lineup for you. We welcome those from Tilganga, Jimma, Hawassa, St. Paul's, Addis Ababa University, Kamfanoche, and Korle-Bu. We are so excited that all of you can be here. And in addition to the amazing residents that come here today and will be with us for the next 18 months in this curriculum, as the opening session, we also have with us an amazing group who have worked behind the scenes from the Himalayan Cataract Project Cure Blindness team. And I want to recognize that they have really been behind all of you to make sure that you get the training that you need, that you get the equipment that you need as you go into your careers, fellowship development, and continuing education. Over the next 18 months, you will see experts from around the world who have and will be putting intense amount of time in preparing lectures for all of you in the realms of the AAO BCSC, the 2021 to 2022 version, which all of you will receive via either WhatsApp or PDF from your program director or head of department. So stay tuned. But this is the order that we're going to go through, starting with cornea for the next 4 sessions, followed by refractive surgery, glaucoma, neuro-ophthalmology, retina and vitreous, pediatrics, ocular inflammation and uveitis, ophthalmic pathology and intraocular tumors, optics, oculofacial, plastic and orbital surgery. And this is really going to be a mixture of your own professors in country, as well as those from around the world. So stay tuned. We have launched through the HCP Cure Blindness virtual classroom, a web page that you are welcome to check out. It's going to be continuously updated and give you information and photographs and updates of milestones along the way, resident stars that come from this audience. And so we have a total of approximately 200 residents. We do have, like I mentioned, an amazing team. It's massive. I couldn't fit them all into the slide. We've got Catherine Oberve, who is our Chief Executive Officer and will be speaking to you shortly. Emily, our Chief Operating Officer. Dr. Geoff Tabin, who will be giving you lecture today, is the co-founder and chairman of Himalayan Cataract Project Cure Blindness. Dr. Sanduk Rui, who may or may not be able to be with us today, but hopefully in future lectures to come. And he is also HCP's Cure Blindness co-founder. I represent the global clinical consultant, and myself, along with Pamela Clapp, who is our senior program director, will be taking care of the training for you along the way. We have as well with us today, Alex Davis, who's the chief of programs, and Dr. Matt Oliva, who will be giving your cumulative book review questions in cornea in session 4. So stay tuned. So rules are only 2, okay? It's very simple. Attendance is mandatory at all sessions, and reading prior to is mandatory. If you do this, we don't ask that you're a first year, second year, or third year, or even a fellow. We don't care your knowledge base beforehand. The idea is that you try, you ask questions, you engage in the chat box, and you show your presence. And in that way, you will learn and get the most out of this opportunity. So with that, I hand it over to Katie Oberbe. She is an amazing human being. She has initiated hundreds of vision centers around the world, and she is on the board of the International Agency for the Prevention of Blindness. And our goal, why are we here today, is so that we make you all the strongest eye surgeons that you possibly can be, greatest clinicians ever, so that you can then take on the fort of being able to cure blindness in your country. So you have a lot on your shoulders, and we are so proud of all of you, and we encourage your participation. So with that, we'd request Katie Oberbay to give us a few words of inspiration.
Thank you, Ashiyana. And hello, everyone. I'm coming to you from very gray London, where I am actually at the Board of Trustees meeting for the IAPB. And, you know, every time I come together with other people who are equally committed to really solving this enormous public health crisis that we have around the world, it's so inspiring. And so, you know, I guess the first thing I want to say is I am actually so honored to be joining all of you here today in the virtual classroom, because we all know that what we all work on, it's going to make a difference and unlock potential in the lives of millions, and dare I say billions of people around the world. And each one of you has an incredibly critical part to play in making a difference in the lives of so many people around the world. So thank you all for everything that you do to, you know, commit to bettering yourselves, increasing your training, and really, you know, increasing the number of people whose lives you can change. I am incredibly happy to be here as the new CEO of HCP. As Ashiyana referenced, I've been working in the vision sector for quite some time, and have, you know, personally seen the tremendous impact that can be made when we bring people together with their, you know, special skills and truly, you know, open the eyes, literally and figuratively, of people around the world. So thank you all for the commitment that you've made. I look forward to walking alongside all of you in this important work. And I'm also incredibly excited to see the virtual classroom come to life. I think it's a tremendous tool, and hopefully will be something that all of you find enormous value coming from it. But again, let me just say, you know, thank you to all of you for being here. It is truly my pleasure to join you. I wish I could stay for the entire meeting, but I do actually have to go back into the other meeting. But Ashiyana, I appreciate your inviting me to come at least for a few moments.
International Agency of the Prevention of Blindness, huge meeting going on right now, and she took a few minutes because she wanted to be with all of you. Everyone that you're seeing here with their cameras on, that have their Cure Blindness shirts on, that is all of our programming team. And so we are just so, guys, show your shirts. I wish I had mine. I wish I had my shirt right now, but show your shirts, because you all are behind the scenes making this happen day in and day out. And I really want the residents to know your faces. I want them to be able to be in direct contact with you. And this is a lifelong mentorship relationship that we hope to forge along the way as their careers progress. I want to hand it over to Dr. Geoffrey Tabin. He is the co-founder and chairman of the Himalayan Cataract Project Cure Blindness. He's based out of Stanford, and he has perhaps one of the busiest schedules of anyone that I know. He is an inspiration who has, when I was in medical school, I looked up to him from afar, I should say. I wasn't even in the same training program, but I looked at his life and his ability to be in so many places at once and be able to impact, to eradicate and eliminate needless blindness in the world. I thereafter, being in the US, I moved to India in 2017, and in my own small way, am walking in his footsteps. So without further ado, I hand it over to Dr. Geoffrey Tabin to give a few words of inspiration.
Hey, everybody. Good morning. It's so fun to be with you all. And you know, our partners, seeing Lena Bhattacharya and Rita Gurung and Seth Larty, and people who I worked with when they were residents and fellows, and now are really leading the charge in around the world I look at us all as partners. I'm so excited to be your partner, and whatever I can do to help facilitate your development, speaking to the residents now, we're here for you. My personal email is just my last name, Tabin @stanford.edu. And my phone is available to you all to call me on WhatsApp if you have problems, difficult cases. And I think this is a really wonderful way of just getting the whole community together to help improve. And I hope that one of the offshoots of this is that the residents in Ghana may reach out to the residents in Ethiopia when you have an unusual case and say, wow, have you ever seen this? And you'll start to be able to, through this forum, get to know your peers in different countries and have the ability to reach out to Dr. Gurung in Nepal, who has so much vast experience, knowledge, and brilliance, and say, Dr. Gurung, here in Ghana, we have this case. What do you think? And also really is a way for all the residents around the world to really link. And one of the things that has been lacking a little bit in the some of the global programs, there's a huge volume of patients, but just that basic core academic knowledge. And this is a really nice way to really get the real depth and breadth of knowledge that you need to take care of all of the patients that you'll be seeing. And going through this whole course is such a fantastic opportunity for you all. I hope everyone takes advantage of it. And I'm excited to be part of it. And as I said, I'm here and I'm available. And I'll be, hopefully as the world situation changes, I'll be traveling in the next year to all the locations. I'll be in Ghana, I'll be in Ethiopia, and I'll be back in Nepal, I think, in May. So I look forward to seeing everyone in person. And please use this as an opportunity to expand your knowledge, expand your connections, and do feel free to reach out to the faculty. The reason we're here is that we really do want to help you. And any interesting, crazy cases. I know Lena Bhattacharya is on the phone. I was trying to direct message her, but it didn't work. So I'll just say it in front of everybody. Lena, if you could give me any update on that really interesting young, unfortunate boy with the bilateral perforations, maybe send it to me by email or text. And that's the sort of interaction I'd love to be getting, where we're all working together and all lifting each other up. So welcome. Ashiyana, thanks so much for setting this up. I think this is a really unique program in the world, and I think it'll make a huge difference. And thank you and welcome everybody.
Today, we inaugurate with the AAO BCSC 2021 to 2022 Cornea book, starting with chapters 1 through 6. Now, before I start, I just want to say a quick plug-in about the importance of reading. When I was doing a fellowship, I think it was my fellowship interview at one of the premier institutions in the US, Duke, I remember that I attended grand rounds, and there were 6 first-year residents sitting in the front row, getting pinged by the chief resident. And I remember one resident who knew all of the answers, and I was so impressed that at the interview dinner, I went up to him and I said, "You are so brilliant. I just don't understand how you know so much." And he said, "It's simple. Before I even started my residency, I read the BCSC book series 3 times over. 3 times over. It's how much you put into it is how much it's going to show up in your future." We have a total of 90 minutes per session. So today we're going to jump right in to Cornea chapters 1 through 6. I'm going to cover chapters 1 and 2, and then have Dr. Tabin continue with 3 through 6. Now, as far as chapters 1 and 2, this is an icebreaker for a treat. So how does it work? It works like this. So I want to have one resident chime in, and Pam, being my sidekick, is going to take note of who volunteers. We want one resident from each program. Those 8 selected residents are then going to be part of this 5-question quiz, if you will, to start, based on chapters 1 and 2. You have to submit your answer to Pam in a private chat. Once she tells me that you're done, that's when I'm going to move on to the next question. Winning resident on behalf of their residency program is going to get pizza, okay? A pizza party with the residents and the residency program director. Question number 1, fill in the 2 blanks below. This is a slit lamp photograph from a patient with what condition, showing staining with what dye? Answer is that this is a slit lamp photograph straight from the book from a patient with conjunctival intraepithelial neoplasia with a dye known as lissamine green. Perfect. Question number 2. Okay, this is from the book, normal cross-section of the cornea, labeled 1, 2, 3, 4, 5. What is number 4? And be specific. And along the same lines, question number 3 goes in line with that. In this slit section of the normal cornea, does the labeled number 4 in the diagram have a higher or lower relative density of keratocytes? So answers to that, it is the posterior stroma that was labeled as number 4, which has a lower density of keratocytes relative to the anterior stroma with a higher density of keratocytes. Awesome, awesome. Question number 4. So these are Elschnick pearls. Elschnick pearls. Question number 5. 6 categories of non-inflammatory corneal opacities were highlighted in your reading. List out these categories. There's a beautiful diagram in your reading on non-inflammatory and inflammatory corneal opacity. There were 6 highlighted in categories for non-inflammatory. What were those overlying categories? So the answer here, and this was the chart that came straight out of your book, okay? Non-inflammatory, the categories were dystrophies, degenerations, depositions, developmental, the 4 Ds, ectasia, and scarring. So it's almost like dry eye syndrome, if you remember it. I love remembering mnemonics along the way. So you're going to hear me, give you mnemonics. So DES, dry eye syndrome, 4 Ds, right? If you remember it that way, to help you, you'll remember the 6 categories of non-inflammatory corneal opacities. In inflammatory, you've got sterile, which can be comprised of local and systemic, as well as infectious, which comprise, as everyone can know, viral, bacterial, fungal, and protozoal. Excellent. Great. Thank you, first of all, for giving in your responses. Today, I am going to whiz through it and really highlight sort of key images very quickly, a few points from chapter 1 and a few points from chapter 2. So with chapter 1, it covered the eyelid. Now the anatomy is critical. And the way I remember it is SOS, right? SOS is a way to say that there's an emergency. In the United States, we say SOS for an emergency. If you see fat, F for fat, then you return to clinic. Because whenever you see fat coming out of the eyelid, something needs to be done about it. So that's the mnemonic that I use to remember the layers of the eyelid. And what are those? So we've got S from outer to inner, S standing for skin and subcutaneous tissue, O orbicularis oculi, S for septum, followed by fat, R for your retractors. Now, what are they? In your upper eyelid, they are the levator palpebral muscle and the Mueller muscle. And in your lower eyelid, it's the capsulopalpebral fascia and your inferior tarsal muscle. The T going more in represents the tarsal plates, and C, conjunctiva. Remember what nerves innervate what. So the orbicularis oculi is innervated by cranial nerve 7. And I remember it like the 7, the hook. So it hooks the eye closed. It's responsible for closing of the eyelid. Versus 3, if you put it into your eye, right, it opens up the eyelid. So I remember it that way. And so your retractors, your levator palpebral muscle is innervated by cranial nerve 3. And your mular muscle, which is also in the retractor category, that's innervated by sympathetic nerves and is responsible for upper eyelid elevation. What are the functions of the eyelid? Very critical. You may be wondering, well, why is this not in the oculoplastic section? Well, it's important for eye protection, tear distribution, ocular surface cleaning, regulation of light exposure, and contribution to the tear film. Moving on to the next topic that was covered in your BCSC was the lacrimal function unit. There are 3 components of the lacrimal function unit. Those are the lacrimal glands, the ocular surface, and the eyelids. And the purpose of the LFU is tear film regulation, production, healing, integrity. It maintains the corneal transparency and also populates the surface stem cells. Finally, the lacrimal function unit maintains the quality of the image projected onto the retina. So remember that the tear film and it's the air tear film interface that is responsible for the greatest amount of refractive power in the eye. So we cannot underestimate the quality of the tear film, which we'll talk about next. But continuing on with the lacrimal function unit, it responds to a number of influences, environmental, endocrinology, and cortical influences. And there's the afferent and the efferent. So the afferent here are mediated by your ocular surface and the trigeminal nociceptors. And your efferent are, what are the components of efferent? Autonomic and your motor nerves. Now, when you look at the efferent specifically, and you break down the autonomic and the motor nerves, the autonomic here is responsible for the meibomian glands, conjunctival goblet cells, and lacrimal glands, and the motor nerves are responsible for the orbicularis function, as well as initiation of blinking. Going on to what we said, the tear film, I cannot emphasize enough, is critical. The quality is so important. And the components of the tear film are 3: lipid aqueous mucin. And it is produced by the following. Now, what's really important, and again, I love key ways to remember things. I remember the tear film layers by LAM, L-A-M. Lipid, which is produced by the meibomian glands. Aqueous layer, which is produced by the lacrimal gland. And M for mucin, is produced by your conjunctival goblet cells. These are things, believe it or not, in my residency program that I took away, and I still remember to date. What are the functions of the tear film? Well, we talked about the quality, but lubrication by the mucin layer, healing, and healing by what? Through the epidermal growth factor, EGF, and protection of the cornea against infection through which defenses? They are the lactoferrins, defensins, and immunoglobulin A. I remember immunoglobulin A came up quite a bit on exam preparations and exams as high testable questions. Layers of the cornea, you all know this, But in the BCSC, they talk about the epithelium, the Bowman's layer, stroma, and then we learned just a few moments ago about the anterior stroma having a higher density of keratocytes than the posterior stroma with a lower density of keratocytes. But what's missing here is the sixth layer of cornea, which was identified in 2013 by Harminder Dua out of the UK. And that's the pre-Descemet layer that lies between the stroma and Descemet's membrane, short PDL, okay? And then comes the Descemet's membrane and endothelium. And why is that important? Because we know about DSEC, DMEC, but there's also another transplant, also known as PDEC, and utilizes that PDL layer. So important to know the layers of the cornea. And this is your classic histopathology of a normal cornea with 4 to 6 cell layers of epithelium. We went through this, but I can't emphasize repetition, repetition, repetition. Looking at this again, number 1 represents the tear film. Number 2 representing the epithelium. Number 3, anterior stroma. Number 4, posterior stroma. And number 5, Descemet's membrane with endothelium. Understand the topographic zones of the cornea with the limbal zones, the paracentral zone, the limbus, pupillary borders, central zones, and your peripheral zone. I'm saying those words, but it is something to just jog your memory of what you would have read already. So chapter 2, corneal opacities, again, recognition, repetition, all of this matters. And so I'm showing you something that you've already seen just a few moments ago. Corneal opacities can be categorized by non-inflammatory and inflammatory. And we remember the 6 categories for non-inflammatory are dystrophies, degenerations, depositions, developmental, 4 Ds, followed by E for ectasias, S for scarring, dry eye syndrome, if you will. Inflammatory can be subcategorized between sterile, which have local and systemic causes, and infectious etiologies. Ocular surface stains are very important, knowing that there are 3 major ones: fluorescein, rose bengal, and lissamine green. Know that devitalized cells is a component of rose bengal, and lissamine green is important and a testable question. Punctate staining, really understanding this chart will help you. All, whether you go into cornea or not, using basic fluorescein staining, you can tell the differential diagnosis based on where it's staining. So let's go through this in some detail. If the fluorescein stain, when you place it in the eye, goes diffusely, you're thinking about viral conjunctivitis, trauma, or toxicity. If it's inferior, you're thinking blepharoconjunctivitis, lagophthalmos, and trichiasis. If it's interpalpebral, in the palpebral zone, we're thinking dry eyes, exposure, or neurotrophic keratopathy. Superior is unique, right? Where we see this would be in superior limbic keratoconjunctivitis, SLK, a foreign body under the eyelid. So always flip the eyelid when you see superior punctate staining on fluorescein examination. Trichiasis or localized limbal stem cell deficiency. Also, when you see it on the bulbar conjunctiva, you have to think about SLK as well. When you see it just localized to 3 and 9 o'clock, we're talking about contact lens. Maybe there's a tight fit there. And if it's lower conjunctiva, it's either a mechanical problem with the eyelid or meibomian gland dysfunction. So go back from what we're talking about today and review some of the things that we're talking about. Slit lamp examination, we can go into a lot of detail here, but just for the sake of time, I want you to just know the words, okay? What are the different interactions of the light rays? There is direct, retroillumination, sclerotic scatter, and specular reflection. Direct, retroillumination, sclerotic scatter, and specular reflection. When it comes to ocular imaging, topography versus tomography, key important concepts to go through, and also the use of other key modalities is anterior segment OCT. With the Tilganga team, we're working on an ocular surface tumor study, utilizing, guys, your anterior segment OCT, which is ultra high resolution. And we've given a lecture to the Tilganga residents on this topic. So utilize that option in your clinic. The more you see normal, the more you're going to understand what is abnormal. So the more you can do and visualize and examine and interpret with your attendings and faculty, the better you're going to be. UBM is a critical component as well. And then on the bottom right, you've got corneal microscopy, identifying corneal nerves. We are all here for you. So if you need anything at all, I am at Nariani at cureblindness.org. I will be with you for the full 18 months. So definitely be in touch. And again, welcome. And we are excited to have you. Geoff, over to you for chapters 3 through 6.
I'm over at Stanford University this morning, and I'm going to talk to you for the next about 30 minutes or so on the ocular surface. And that was a wonderful introduction from Ashiyana about, the anatomy. And I have no financial disclosures on this. So the ocular surface, as you heard from the anatomy, really is made up of the lids, which spread the tear film, the tears, you have your corneal epithelium, and the conjunctival epithelium. And that's the surface of the eye. And that really, as Ashiyana said, the most important refractive interface for vision is the ear to tear film interface. So if you have a dry eye or a wet eye, it's going to upset your vision. The corneal epithelium, one thing Ashiyana didn't mention, which is really critical, is that it has the highest density of sensory pain fibers in the entire body. So it's very, very sensitive, and people have a lot of pain. So ocular surface disorders, one, disrupt the vision, but two, they can be very painful. And she mentioned the staining, and that when you stain with fluorescein, you see areas of irregularity and missing epithelial cells. The nice thing about rose bengal and lissamine green are that they will stain, as Ashiyana said, devitalized epithelial cells. But there's one problem, which is that especially rose bengal hurts. When you put it onto devitalized cells, there's sensory pain fibers that act up. So actually, it's if you have a really terribly complaining dry eye patient, one way to get them to go to another doctor is give them rose bengal every time they visit you. And when you have someone with surface issues and sort of surface disorder, one of the things you want to look at are the tear film, and you want to look at the tear breakup time. And to do that, you put a little bit of fluorescein dye in, you have the patient close their eye, then open, and count how many seconds it takes to have a dry spot on the cornea. And things that'll lead to an increased tear breakup time are evaporative loss. So if you have very bad meibomian gland disease, and also goblet cell deficiency. And the goblet cells make the mucin, which keep the tears attached to the microvilli on the cornea epithelium. Then you want to do the stains, as Ashiyana mentioned. Hello? You want to use stains such as rose bengal, which is the most sensitive, but unfortunately kind of painful. Fluorescein works very well. Then you want to look at what is the tear production. And what you do is Schirmer's 1 and Schirmer's 2 are basic secretion. You put a little filter paper strip in and see how much tears are produced in a matter of 5 minutes. And I personally usually use, when you use no anesthetic, which is the true Schirmer's test, it is a little uncomfortable for the patients, and you're measuring both your basal tear secretion and your reflex tear secretion. And I tend to mainly look at what is the basal tear secretion. And there's really a very important thing also. You want to check the sensation of the corneal nerves. And then we have some fancier tests looking at the osmolality of the tear film. So this is a very bad ocular surface, you can see, with rose Bengal staining. And when you have a bad surface, you have pain, foreign body sensation, decreased vision, and tearing. And sometimes these will come in and not be as dramatic as that last slide. They'll just be a little bit of staining, but the patient is really miserable. And one thing you always have to ask yourself, particularly, in Africa and Asia, you're dealing with so many horrible issues. You have people with Morin's ulcers and severe infectious keratitis and really vision-threatening conditions. And then you have a patient come in and goes, "Oh, my eye hurts so much." And you look at them, their vision is 6.6, and you look at the staining, and there's just a little bit of staining. But one thing I always try to remind myself is that this is the most important eye condition that this patient has. And dry eye is really a serious issue. It's one of those sort of frustrating ones, because as we try to treat someone with just simple dry eye issues, if they're not putting in enough drops or their exposure continues, they have pain and fluctuating vision. And it really is the most important eye condition of that patient. So I always take a deep breath and try to approach it from the standpoint of, how would I feel if this was my patient? The structure of the tear film, as you heard from Ashiyana, you first have the microvilli of the epithelium, which the mucin layer embeds with, and that allows the rest of the tears to stay. Then the aqueous layer, and there are a lot of components in the aqueous layer. As you heard, it's very bacteriostatic with secretory IgA, but it also, the aqueous tear layer washes invaders out of the eye. And then you have the superficial lipid layer from the meibomian glands that keeps the tears from evaporating. There are a lot of systemic diseases that will interact on your ocular surface and are very important in the way you treat them. The most important and common one is rosacea. And then there's also a lot of different reasons for meibomian gland dysfunction, seborrhea, sarcoidosis, ichthyosis, and xeroderma pigmentosum, all affect the ocular surface in big ways. And when you look at a dry eye, you have to really try and assess, is this more from aqueous? Is it from the meibomian glands? Is it a problem from the goblet cells? Or is it a problem from the lids and leading to exposure, or a mechanical reason? Meibomian gland disease is extremely common. A lot of the ubiquitous bacteria, the staph epidermidis, all kinds of your skin surface flora can get into the meibomian glands. The meibomian glands tend to get inflamed, and they can sort of obstruct, so you don't have any secretion of the meibomian glands. And another condition, seborrhea, will also block the meibomian glands, and that leads to evaporative tear loss. So even though a person is making a normal amount of tears, they have severe dry eye issues because they have the surface dry. And this is our fancy word, inspissation. And so these are inspissated meibomian glands that are kind of like pouting, and they don't secrete. And you want to take a little Q-tip and just sort of push on the meibomian glands and see how they secrete. You can use a little cotton applicator and just sort of gently roll, and you want to see that nice oily secretion. Another thing you want to look for are chronic obstructive changes. You get these blood vessels growing across and an inflammatory membrane across the orifices of the meibomian glands. And so you really want to, on your exam, see what are the secretion of the meibomian glands. And if you catch it early, these are people who you can make a huge difference just doing warm soaks and really good hot compresses, maybe a little bit of bacteria. You want also, when you're looking at people with chronic meibomian gland disease, also look for skin disorders. And this is showing rosacea. It's a very common, it's an idiopathic inflammatory condition of the oily glands of the central face. And just as you see the nose and the oily glands in the nose are involved, you can see very well the eye. And a lot of times the inflammation is a little bit deep in the meibomian glands. You treat with warm soaks, steroid antibiotic drops sometimes don't penetrate. So I like to, when I see meibomian gland disease associated with rosacea, I go pretty quickly to doxycycline. And doxycycline has both the antibiotic, bacteriostatic nature of the drug, but it also is a metalloprotease inhibitor and helps with the inflammation. And it also needs to be mentioned that when you have someone with doxycycline stains, one of the side effects, the permanent teeth of neonates in children. So if you have a woman who's pregnant or you have a woman who's breastfeeding, you absolutely don't want to give them the doxycycline. Another thing that affects the ocular surface is the overall health and nutrition. This is vitamin A deficiency, and it's still very common, particularly places in Ethiopia, places in southern Nepal, and you'll see children who don't have vitamin A in the diet, and that is a big factor affecting the ocular surface and leading to one of the initial things you'll see is the dryness and cirrhosis, and it affects the ocular surface. And if it's not recognized and you don't treat it, you give 10,000 international units of vitamin A day one, 10,000 international units of vitamin A the next day, and then 1 week later. And these children will develop very severe dry eye signs and symptoms, and it can lead to melting. So now again, when you have the dry eye, don't just dismiss them and say, oh, your eye's dry, here's artificial tears, go away. You really want to see why is the eye dry and really try to help. These are some of the patients who, as I mentioned, are some of the most frustrating, and they can be patients who you look at them and say, this is such a minor thing. But again, to the dry eye patient, this is the most important eye disease that they have. They come in, you want to look at whether, it's kind of a busy slide here, but whether it's an evaporative issue or whether it's an issue with tears not being made. And, Sjogren's syndrome is a condition where the antibodies attack the lacrimal glands and you have a decrease in aqueous tear production. And it can be associated with a lot of other autoimmune diseases, rheumatoid arthritis, lupus, Wegener's, but it also can be associated with also older age. It can be hormonally related. And so there are a lot of different reasons for having less tears. The other thing is there's the big reflex arc. When you have a neurotrophic cornea, there's not the sensation of dryness that gets sent. There's a reflex that goes out along the fifth cranial nerve to a couple of interneurons to rejoin the third nerve and come back to the lacrimal gland to give reflex tearing when the eye starts to get dry. So people with neurotrophic keratitis lose that. So anybody who has a loss of sensation, you have to worry about dry eye signs. And they can be very tough because they don't often feel the pain. And so things can go quite badly for them and get secondary infections. Then there's evaporative tear loss. And you always want to look for, is there an abnormality in the eyelid? Is there an abnormality in the way that the lids are what sort of spread the tears? So it's really important to look at see if there's a mechanical cause for the evaporative tear loss. One group that has, just for instance, evaporative tear loss is people with Parkinson's disease. And people with Parkinson's disease have a decreased blink rate. And so even though everything you look at anatomically looks fine, and you tell them to blink and their blink is perfect, they'll go 20, 30 seconds without blinking. And so you always want to sort of look at the overall person in addition to just exactly what's going on in the eye. And evaporative loss, again, with meibomian gland dysfunction, abnormal meibomian gland secretion. And a lot of these conditions go very much hand in hand with other clinical entities like blepharitis. What happens when you have decreased tear production, you're not washing the bacteria out of the eye at the same rate. And so the bacteria, the normal flora of the eye doesn't get washed away. So particularly staph and strep can get up into the meibomian glands, they can get up onto the eyelids and escape the immune system. So everything kind of goes together. So you want to, again, look for low blink rate. There are a lot of drugs that can be extremely toxic on the ocular surface. People with mild amount of dryness who wear contact lenses, the contact lens can absorb the tear and lead to more dry issues. Then another thing to think about is that also a lot of ocular surface disease can be related to allergy and itching. And when someone itches, when you have mild dry eye, people will rub their eye because they're trying to squeegee the scant amount of tears onto the dry area. But also itching creates defects in ocular surface issues that can really affect the vision. And one way you can tell if someone is rubbing their eye with your normal staining with fluorescein, the staining with dry eye is just on the cornea. If you see staining on the conjunctiva, that is usually pathognomonic of the fact that the patient is rubbing their eye. And you can get a very bad ocular surface from simply rubbing your eye a lot. It's kind of a busy slide, but you really want to see what you can do on all the different areas. One thing people have been looking at is the osmolality, or the amount of protein that is within the tears. And when you have less tear production, proteins build up, and that gets very irritating. And when that gets irritating, that leads to immune cells coming in. And so now you have this stimulation for immune cells, which makes the tear film even more viscous, and you get into a very unpleasant cycle. So often steroid eye drops can be a very big component in how you make people feel better and treat and combat severe dry eye. And as we all get older, there's a little bit of a decrease in tear production. There's been some association with androgen production, and there are also many systemic drugs that can affect the tears. So it's really a circular process with bacteria, from the lack of secretory IgA and lack of flow, and getting inflammation from the eyelid. And it can be a really, really annoying, chronic, unpleasant condition. And it's something you see, age-related, and a lot of different diseases. And you want to really try to figure out what are the sources, and then more importantly, how can you how can you help the patient the best way you can. Chemical and thermal burns will often destroy the goblet cells, so the tears don't stay. And I mentioned before, look for the neurotrophic things and sort of really try to isolate. And a lot of times things go together. You have both an evaporative dry eye state plus a aqueous deficiency. And so what you want to do is try and first line of therapy is really just replace the tears with artificial tears. There are several brands that also have more of an oily component that that allow the artificial tears to stay a little bit longer. If there is anything going on with the bacterial infection in the lids or the meibomian glands, you want to treat your meibomian gland disease. Often you need to really use a anti-inflammatory, a steroid, to break the cycle of inflammation. And one thing, this is blepharitis, which is, again, very, very common in dry eye because the tears are not washing out the bacteria and not stopping the bacterial ingrowth. And so you want to approach dry eye from all different angles, and really each individual patient is presenting a different problem. The treatment options are, as I mentioned, the tear replacement. You can include one punctum. Sometimes if you have very severe Sjogren's type dry eye where the lacrimal glands are no longer producing any tears, that will do a punctal occlusion relatively quickly, and even do punctal occlusion for both the lower and upper lid. But then they have to, a few times a day, really irrigate out all the proteins and debris from the eye. Moisture chambers or little suction cup-like glasses, they can make a big difference. Particularly if there's a fifth nerve palsy and exposure, I go right away to a tarsorrhaphy. So those of you who know math, if you think of what is 5 + 7 equal, and the answer in ophthalmology is T. So 5 + 7 always equals T. If you have a fifth nerve palsy and a seventh nerve palsy, go right away to a permanent tarsorrhaphy. Then again, to break the inflammatory mediation, topical steroids are kind of the go-to for long-term restasis and Xiidra, and those are cyclosporin A. Cyclosporin A is a drug that was discovered by Joe Murray. He won the Nobel Prize for doing the first successful kidney transplant, and he used cyclosporin A, works both decreasing T cell recognition and T cell recruitment as a sort of intermediate measure when you have a chronic epithelial defect from ocular surface amniotic membrane, works very well as a substrate for epithelial migration and also to decrease the inflammation. There are a lot of very good anti-inflammatory elements in the amniotic membrane. The PROS lens is a large sterile contact lens that allows moisture inside the lens and really can help the surface. Final thing that I didn't put on this slide that should be here are serum tears. And you can, in America, there's a couple companies that make it for us, but you can take the person's blood and you sort of spin it down and make artificial tears out of the person's own serum. And that has a lot of the elements of tears that you don't find in simply the commercial brands. And just to remember, it's not an ophthalmic nuisance, it's an immune-based inflammatory ophthalmic pathology. And even though it can seem very mild to you, as I mentioned to the patient, it's a very serious thing. And so we want to, sometimes the signs and symptoms don't always correlate. And you know, things you're going to be getting are blurred vision, severe sensitivity to light, burning, stinging, foreign body sensation. And, you know, it's our goal really to figure out where the signs and symptoms are coming from and restore an ocular surface. And Ashiyana went over with the staining patterns and what you want to think about from the staining patterns, but it can all be confounded because a lot of people will also rub their eye, and you can have fairly diffuse staining in severe dry eye if people rub their eye. So it won't necessarily be just intrapalpebral. And we talked about the evaporative dry eye, and you always want to look for ineffective blinking. And as I mentioned, you know, Parkinson's disease, but also lag ophthalmos with Graves, eyelid retraction, and quite a few of the neurotrophic diseases. And there's also been some studies that have shown you may find that there are more elderly women who come in complaining of dry eye issues. And there's quite a lot of interaction between hormones, especially the androgens, which significantly decrease after menopause. And there have been some studies in dog models showing that replacement of androgens can make a big difference in the dry eye pathology. So when you have an elderly woman, you want them to pump up like Arnold, give them androgens. No, that's not the way you would treat it, but there is a lot of exciting research coming on ways that we can help the sort of common dry eye of elderly people with cyclosporin A, and basically looking at trying to decrease the inflammation. So the conclusions are you really need to maintain an ocular surface. If you have meibomian gland disease or rosacea, you want to try to treat them aggressively. Warm soaks, antibiotic steroid drops, oral doxycycline. You want to give people preservative-free tears. A lot of the sort of the signs and symptoms can be perpetuated by preservatives that irritate the ocular surface. And the toxicity is a big issue for compounding and even mimicking dry eye. So you want to give preservative-free tears. You want to give maybe topical steroids, cyclosporin A. Autologous serum is really a great modality. Punctal occlusion to keep the tears around more, tarsorrhaphy, moisture chamber, and scleral contact lenses. And really you want to, I always think about when I see dry eye patients, I want to get them to happy eyes. And a lot of times it becomes like the sole thing in their life, and you really want to get them to happy eyes. And what about this? This is this patient with leprosy. And leprosy, you often get a fifth nerve palsy and a seventh nerve palsy. As I mentioned, 5 + 7 = T. You'll also see fifth nerve palsy with herpes zoster. You'll see it with herpes simplex. And always be worried about someone who has a normal tear production and they don't seem to have bad meibomian gland disease and have bad ocular surface. Think about herpes simplex, think about herpes zoster. And this is a neurotrophic ulcer. And when you see a neurotrophic ulcer, you want to think about what can you do to prevent this. Usually a neurotrophic ulcer, you're going to need to do a tarsorrhaphy. There are other structural disorders. This is the one on my left is floppy eyelid syndrome. And what you'll see is this kind of fine velvety look on the on the conjunctiva when you evert the lid. And these will evert spontaneously while the patient's asleep, and they will get horrible ocular surface disease. And if you just look at them, if you just look at his right eye, it doesn't look that bad. And you'll measure the tear production, it's normal. You look at the meibomian glands, they're normal. But as soon as you start to move the lid, you see it says this floppy eyelid. You just need to see Mr. Floppy once. And another thing to look at are notches in the eyelid, any sort of eyelid defect. Another thing is people who have sleep apnea, and a lot of the sleep apnea devices will blow air up onto the lid while the patient, and onto the eye while the patient's sleeping, and they'll wake up with severe ocular surface disease in the morning. Another thing you want to kind of look for, it's sort of a subtle and often missed, is nocturnal lag ophthalmos, and patients who don't fully close their eye at night. So you look at them in the office, they're fine, but if you ask their partner, their husband or wife may tell you they sleep with their eye open. And you can sometimes just have the patient gently close their eye and see if there's a little bit of lag. So nocturnal lag ophthalmos is something you don't want to miss. This is superior limbic keratoconjunctivitis, which can lead to very bad, severe surface disease and chronic discomfort. And you want to always make sure you have the patient look down and look at the superior limbus. And then there's always keep in mind that with surface disease, herpes simplex virus, herpes zoster virus, also the anterior basement membrane and other dystrophies can lead to chronic erosions and epithelial defects and recurrent erosions. So always keep in mind the recurrent erosion syndromes where you get a little bit of protein that gets deposited at Bowman's layer and the epithelium doesn't remain stable. And then this is a pretty extreme example, but subtle eyelashes and distichiasis, having just a couple of eyelashes growing out of the meibomian orifice, can really drive people crazy. And then what do you do about the limbal stem cells? And we'll turn our attention now from the surface to the limbal stem cells, which are also really important in populating the ocular surface. And limbal stem cells are as the limbus, are pluripotential stem cells. They're not sort of native stem cells. They can either become conjunctival epithelium or corneal epithelium. They're defined by capacity for prolonged self-renewal, and they have a lot of their niche. Really, what happens to them is very important. Their contact with their surrounding cells, and they are not embryonic stem cells. And you can have limbal stem cell deficiency that can be hereditary, as in aniridia, multiple endocrine deficiency, and epidermal dysplasias. But more common, you'll see it is an acquired, either from chemical burns or thermal burns, Stevens-Johnson syndrome. People have multiple surgeries, so sort of a nasal and medial pterygia. People who have contact lenses can actually do it. Multiple bacterial infections, and sort of there's a whole litany of reasons why you would get limbal stem cell deficiency, and it can be a very frustrating disease to try and manage. So I try to figure out whether it's congenital, traumatic, iatrogenic, immune, neoplastic, and the upshot is that you have conjunctivalization of the cornea, and if you have a chemical injury or a thermal injury, you want to right away treat very aggressively with anti-inflammatories, and I like this. This is a patient I'm going to show you a little bit later. This is a young boy who I took care of, who fortunately just had the limbal stem cell injury to one eye. And but you also can, worry about it if you have multiple surgeries, you have pterygia, recurrent pterygia, you're doing multiple autografts. And then it's very common with Stevens-Johnson syndrome. And so what happens, you start to getting conjunctivalization of the cornea, you get a thickened, vascularized, irregular surface, persistent epithelial defects, ulcerations, scarring, and even loss of the eye. So this is stromal ulceration and sort of end-stage limbal stem cell defect. So what do you do when you have limbal stem cell defect? Well, again, the first thing is to try and prevent it, but then if you can't, you want to start trying to reconstruct the surface. The first person to talk about surgery to restore the surface was Richard Thoft, who had an unfortunate name, Dick Thoft, but he was a brilliant corneal surgeon. And he started talking about conjunctival transplants. He helped pioneer conjunctival transplants for pterygia. And then Ed Holland in America has been one of the ones who've really kind of taken limbal stem cell transplantation to a different level, preparing the grafts. The problem is that these are very close to the limbus. So when you do a keratolimbal autograft, they have a high tendency to reject, and you need to use a lot of immunosuppression. And so a lot of people looked at, well, can we grow a person's own limbal stem cells and expand it, and particularly if you only have one eye injured. And Virender Sangwan, who was at LV Prasad Eye Hospital, he's now at Shroff's Hospital in Delhi, came up with the idea of, instead of doing an autograft, doing a graft from the patient's fellow eye if you only have one eye injured. And so he came up with the simple limbal technique, a simple limbal and epithelial transplant technique, where you use your fellow eye and you use the eye that's been damaged as a tissue culture. He started out trying to take samples of limbal stem cells, grow them in a tissue culture in the lab, then put them on an amniotic membrane and then transplant them on. This is a technique that works very well when you have unilateral limbal stem cell defect.
Simple limbal epithelial transplantation, commonly called SLET, is a technique first described by Dr. Sangwan for unilateral cases. First, limbal biopsy is harvested from the healthy eye and preserved, followed by pannus dissection in the affected eye. The amniotic membrane is applied and small bits of limbal biopsy are secured over it with fibrin glue. We shall now demonstrate the steps of limbal biopsy. In the donor eye, a 2 by 2 millimeter area is marked centered on the superior limbus. The conjunctiva is incised and a subconjunctival dissection is carried out until the limbus is reached. A shallow dissection is then carried out 1 millimeter into the clear cornea, and the limbal tissue is excised. It is then placed in balanced salt solution. In the recipient eye, a 360-degree peritomy is performed, and the vascular pannus covering the cornea is removed. After cauterization of the bleeding points, human amniotic membrane graft is placed over the barren ocular surface. It is then secured with fibrin glue. The excess membrane is trimmed and its edges tucked under the surrounding conjunctival margins. The donor tissue is then gently held with forceps and cut into 8 to 10 small pieces with either Van Ness scissors or a number 15 surgical blade. The small limbal transplants are placed epithelial side up on the human amniotic membrane and distributed in a circular fashion around the center of the cornea, taking care
to avoid the visual axis. However, there is no specific pattern defined for placement of these small limbal transplants. The transplants are then fixed in place with fibrin glue. A soft bandage contact lens is placed on the recipient eye, and 1 drop of 2.5% povidone iodine is applied to both eyes.
So anyways, this is a patient of mine. That's that boy you saw who had the alkali burn, and he developed severe limbal stem cell deficiency. And I did Dr. Sangwan's SLET technique. And here's the boy 2 years later, he's seeing 6.6. And so SLET is great for unilateral cases. For bilateral limbal stem cell deficiency, we're still struggling with fairly severe immune suppression and doing limbal grafts from donor corneas. The final option is a keratoprosthesis, which has complications of glaucoma and also membranes behind the prosthesis. So the biggest takeaway points are that ocular surface disease is really a very chronic, but a really severe condition that affects a lot of people. And even if they're just mildly decreased in vision and have chronic discomfort, that is the biggest issue to them. And really take your time to try and figure out what is the cause of their ocular surface deficiency. Is it from the aqueous tears? Is it from the goblet cells? Is it from the meibomian glands? Is it a combination? And really work hard to give them relief. And for the sake of time, I'm going to go on now, and I'm going to go to the next lecture, which is congenital abnormalities of the cornea and sclera. And this is microcornea, and it's defined as being less than 9 millimeters in a newborn or less than 11 millimeters in an adult. Usually the cornea is clear. It's often associated with the PAX6 gene. It's autosomal dominant. They often have severe hyperopia. They have small eyes. There's a severe risk of angle closure and a very high risk also of open angle glaucoma. It's associated with quite a few other syndromes, particularly dwarfism and fetal alcohol syndrome. They often have congenital cataracts. There's really no specific treatment. The prognosis is usually very good with microcornea. The problem is it's difficult to do cataract surgery if they do develop cataracts, and they also are at high risk for glaucoma. And this is megalocornea, and megalocornea is defined as a clear cornea larger than 13 millimeters, and it's usually bilateral. It's tends to be non-progressive, and you could please hold on for a minute. It tends to be non-progressive. Some are X-linked and also associated with Marfan syndrome. And the big thing you want to do with megalocornea is make sure it's not associated with, it's not associated with having congenital glaucoma, because congenital glaucoma will give you a large cornea, and so that's really, really important. The difference is you're not going to have the Hobstria, you're going to have a normal interocular pressure. And with congenital glaucoma, the axial length increases, whereas with a megalocornea, that won't happen. Cataract surgery is very difficult, both due to the zonular loss and also the large sulcus. And there maybe a good candidate for you have use capsule tension rings or all iris fixated IOLs. And this is a side view of cornea plana. You see there's a very flat cornea. It leads to huge amounts of hyperopia. The power is usually in the 30s. And if the cornea is not clear, then this is an example of sclerocornea. And that and treatment tends to be, again, managing the IOP because they're very, very high risk for angle closure glaucoma. And this is, everybody should be thinking about what it is. It's something you'll see fairly frequently. This is posterior embryotoxin, and you have anterior displacement of Schwabe's line. And again, Schwabe's line is where Descemet's membrane ends and the trabecular meshwork begins. It can be an isolated finding, or it can be associated with several syndromes, Axenfeld-Rieger syndrome, and also it's very common in aniridia. And this is Axenfeld-Rieger syndrome, and it's a spectrum of anterior segment disorders. You have posterior embryotoxin, but you also get iris strands and iris hyperplasia. You have irregular pupil. They're also at very high risk for glaucoma, and they also have dental, facial, and skeletal abnormalities. And when you have the scarring with this, that's then Peters anomaly, and you get a central or paracentral corneal opacity at birth. There's localized absence of endothelium of the cornea. Unfortunately, 80% of these are bilateral, and they also have a very high incidence of glaucoma. And it's really an embryologic finding. It's almost like a hernia that develops in the embryology. And one thing that I try to do in kids like this, they're very, very high risk for very high risk for a keratoplasty. And one thing I do is an eccentric iridotomy. So you do an optical iridotomy or optical iridectomy if there's a small clear place in the cornea. And this is posterior keratoconus. And you have a normal anterior shape of the cornea, but you have posterior thinning. And these you just need to treat with astigmatism management and treat the amblyopia. And you can pick this up on several of the new topography machines. This is sclerocornea. It's sclerosation of the cornea. It can be peripheral. It can be the whole cornea. These are difficult to treat. You need to do a transplant. And the problem is these kids are young and have a tendency to reject the cornea, as it takes a lot of management. This is an anterior staphyloma with keratoctasia, and it's a disorganized anterior segment. These are really not possible to reconstruct, unfortunately. Congenital corneal keloids associated with Loeys syndrome. And then you also can get congenital anesthesia of the cornea. And this is a really tough one. They get painless corneal opacities. They're very highly susceptible to getting epithelial defects and secondary keratitis. Now, these are Hobbs stria from congenital glaucoma. And again, you need to differentiate congenital glaucoma from megalocornea. Congenital glaucoma, you need to do surgery. And they have an enlarged overall eyeball, and they have cornea edema, and you'll see the stress lines in Descemet's membrane that are horizontal, which are the Hobbs stria. When you have vertical stria like this tends to be more common from birth trauma, when you have the paddles go in to try and bring the child out, and they usually have corneal edema that lasts a few days after delivery. You get vertical lines in Descemet, and sometimes you can have amblyopia from scarring from the birth trauma. And I think I'll stop there. The next section is depositions and deposits. It's about 9 o'clock, so I'll turn it back to Ashiyana for the next step in the discussion.
I want to hand it over to the cornea experts in the group in the classroom that are here in the background to support your education. Dr. Rita Goreng, Dr. Lena, Dr. Rachana are all here from the Cornea Department of Tilganga Institute of Ophthalmology, Dr. Gladys Forger from Ghana, and Dr. Netta Nickpour from the USA, who was a previous HCP Global Ophthalmology Fellow. Dr. Rita, we'll start with you first.
Oh my goodness. As Geoff mentioned about KLAL, but in our countries, like in Nepal or in Ghana or in Ethiopia, it will be very difficult to follow up or manage those patients because the patients has to be under rheumatologist care because of they have to have lots of immunosuppression. So the SLED technique, which Geoff very nicely showed in his slide and in the video, that which can be done very well, and because but it can be done only in a unilateral patients, patients who had a problem in one eye, especially in India or in Nepal, where the parents or the fathers usually they have this tobacco. They have to put lime in that tobacco, and they ask the boys or the children to go to the shop and then buy the lime for them, and that's how the accident happens. And lots of work has been done by Namrata Sharma from AIMS on this. As far as the corneal problem in our countries is concerned, like in our big surveys in Nepal, it used to be almost 10% of the blindness was due to corneal problems, and the most important was trachoma that time in the 1980-81 survey. But now trachoma has been eliminated from the country, vitamin A deficiency, and Geoff was mentioning about the boy Lena, and Geoff operated on. Most likely the boy is vitamin A deficient boy. So we do get children not very often, but we do get children with vitamin A deficiency, keratomalacia. So we have to keep our eyes open for this kind of problems too. As almost at the end, Geoff was mentioning about the optical iridectomy. Maybe our generation of people know about the optical iridectomy, but this is very handy in the places where the corneal tissue is scarce, and we might have to do a big optical iridectomy. Most likely it would be beneficial for the patient if we can do somewhere inferionasally, so that for the close work, they can use that little hole in the iris to see near objects. So and that is a very handy and quite straightforward kind of operation we can do in patients with corneal opacity where the tissue is not very readily available. Otherwise, thank you, Ashiyana and Geoff. Wonderful lectures.
Dr. Rita, thank you so much. The tuna injury, the Lyme injury in India is definitely the leading cause for limbal stem cell deficiency for our children. So absolutely a vital pearl for everyone to know. Dr. Lena, over to you for pearls.
And I'd like to add a few things about herpetic eye disease associated dry eye. Sometimes I encounter filamentary keratitis with a past history of recurrent viral keratitis, and I give in those patients, besides refresh tears and topical steroids, I also give acyclovir tablet twice a day, 400 milligram twice a day, even if the patient doesn't have stromal inflammation or herpetic active herpetic disease. And I find that after giving acyclovir tablet, those type of dry eye, they improve, and I continue the tablets for several weeks along with topical steroids, even if I don't see any stromal inflammation or active herpetic disease. I have treated a few patients like that.
Dr. Rachana, over to you.
Yeah, good evening, Ashiyana. It's good to see you after a long time.
Nice to hear your voice, really.
Yeah, it's good to see. And as Dr. Lina has already said, Dr. Tabin has almost covered all the chapters so concisely and precisely also. So regarding to his lecture, so as Dr. Lina said, we have so many of herpetic eye disease and other types of viral keratitis in Nepal. So that keratitis is going to cover in next lecture by me and Dr. Lina. So, so I think this lecture helped our residents in a very to understand the AAO, which is quite vague, in a very precise manner, and they will learn how to how to give importance to the important chapters and the headings also. Thank you so much.
Thank you, Dr. Rachana, and to that, a very hearty congratulations to Dr. Nishkal from Tilganga Institute of Ophthalmology for winning today's session. Pizza party is due for all of the residents in Nepal in December in person. Yes, and we want to emphasize, it's not that you have to be a senior resident to win. You have to read, you have to be present, you have to engage. The next time, there will be also a small prize when Dr. Lina and Dr. Rachana are giving their lectures. But the criteria for that time is who gives the most number of questions on the chat group. The winner is going to be the one who gives the most educated questions and the most number of questions on the chat box. Dr. Neda Nikpur, over to you.
Thank you, Ashiyana. Thanks, Geoff. Thanks, everyone. It's so great to see everyone. Thank you for putting this together and including me. I agree with everything that's been said, that there's so much that's already been covered by Geoff. One thing I would add, specifically as it relates to topics that he discussed, is neurotrophic keratitis. I think is very underdiagnosed. And as a cornea fellow, I remember associating neurotrophic keratitis with severe melts and, really difficult to heal ulcers, but it's probably more prevalent than we think it is. And especially I would urge people to pay attention to checking corneal sensation before you put an anesthetic drop in the eye. If there's, infection and infectious keratitis that's not responding to treatment, a lot of times towards the late stages of treating a corneal ulcer, you have so much medicamentosa and toxicity from all of the drops that you've been using that really at that point you have to wonder if the infection's already sterile, and then maybe you have a neurotrophic component. Maybe you need to actually try stopping everything, lubricating the eye, aggressively lubricating, treating the ocular surface. Like a lot of the things Geoff was talking about with treating dry eye also work in treating corneal ulcers, because a lot of times when these patients get neurotrophic, they can be really difficult to treat. I would pay particular attention to diabetics because they're often neurotrophic. And, even in just treating corneal ulcers, one of the things that I think is really useful is the breakdown of different categories of disease, like you talked about in the beginning. A lot of times if we see something white on the cornea, we wonder, is it infectious, is it inflammatory? It's really helpful to take a step back when something's not responding to treatment and ask yourself, am I even in the right category of disease? I'm treating an infection thinking it's an infection, but maybe it's not an infection anymore. So I really like, trying to step back and think in broad categories when you're addressing whether it's a red eye or a corneal ulcer or whatever it is, trying to make sure that if you're not responding to treatment, that you're on the right track with what you're doing. And the other thing that I think is often overlooked in corneal ulcers and underutilized is doxycycline and vitamin C. And those are very helpful things to add. Yeah.
Beautiful, Pearls, really taking it residents off the page and making it real. That's the goal. So beautiful, Pearls. We are going to end with Dr. Gladys from Ghana.
Hi, everybody. Thank you so much for organizing this. Really great lectures. What I wanted to just add, again, I think my senior colleague just said that trachoma had been eliminated in Nepal, if I'm right. Ghana has also eliminated trachoma, but we've seen a few of the complications, so we still look out for them. Now, the other thing that we keep getting is criminal chemical injury. Unfortunately, we have people who are splashing other people's faces with acid. So that is a huge thing for us. And we get them with a whole lot of ocular surface issues. And then Steven Johnson syndrome is one thing we're also seeing. And they're coming with really, really bad ocular surface. So getting the knowledge to manage these ones is really, really essential. Now, venous keratitis is something that we think is really, like mild, but we are seeing a few very bad ones. They come with really bad limbal stem cell disease. And we are lost as to how to go on because we don't have the things to work with. She's helping us with how to get our amniotic membrane. So once we can get that going with Dr. Amwa, Dr. Latte, we'll be able to help some of these patients. Thank you so much.
Dr.
And just to add that we're also able to get our serum for tears. So that's another plus. Thank you.
Serum tears, that's a fantastic milestone. I'm so happy that you talked about the amniotic membrane. Even South Sudan wants to be able to harvest that. So that is a really great step forward. We've got Netta Nikpour on the line, and she, during her fellowship, was working on this with multiple HCP partners. And so we can definitely pull her expertise in this field onto that conversation as well. I am so happy. See, the thing is that everyone should hear again and again is that we want your success. And that's why everyone is here. I mean, it is past 11 p.m. in Nepal, right? And it is, I don't know, 7:30 in the morning or something like that for Dr. Nikpour in Hawaii. But everyone is here to show their support, not just today, but for whenever you need them in your academic journey and career and beyond.